Hello, thank you for joining us today for our presentation on latest advances in the treatment of acute stroke. My name is Gina Ora, and I'm the physician liaison at McLaren Bay Region. We are excited to have you join us for today's program. During today's broadcast, as questions come up, please feel free to comment and they will be addressed at the end of the presentation. I am honored to introduce Jordyn Kippe, physician assistant with McLaren Bay Neurology. Welcome, Jordyn.
Thanks, Gina, for the introduction. So as she said, my name is Jordyn Kippe, and today I'm going to present on the latest advances in the treatment of acute stroke. So just a quick introduction about myself. I spent 2 years working in neurosurgery, and I've now spent 3 years working in neurology at McLaren Bay Hospital. I had 4 years of clinical research in stroke and brain cancer before becoming a PA. I've done an extensive amount of teaching over the years, and I do have some fun hobbies that include wakeboarding and water skiing. I know people think that I spend all my time in the hospital, but I do get out on occasion. So let's get into the PowerPoint. Ischemic stroke, some of the basics. An ischemic stroke, the basic definition is that it's damage to the brain from an interruption of its blood supply. This interruption usually is caused by clots within the arteries of the brain. However, this blood supply interruption can also be if there is a hemorrhage, so the blood comes out of the artery. A stroke is a medical emergency. Symptoms of stroke include trouble walking, difficulty with speaking, either getting words out or understanding speech. Understanding speech, as well as paralysis or numbness of the face, arm, or leg. Early treatment with medications like TPA, which I'm going to talk about in a moment, can minimize the brain damage caused by stroke. And there's also other treatments for stroke that will focus on limiting the complications and preventing additional strokes that I'm going to cover today. So tissue plasminogen activator, also called TPA. This is given to treat acute ischemic stroke if a patient arrives in the emergency department within 4.5 hours. Some instances we can give this out to 6 hours, but the rough time frame is 4.5 hours of symptom onset. So TPA is a medication, once again, within that time frame. So if, for instance, somebody ended up developing the symptoms in the middle of the night, we have to go by the last time we knew they were well. So the last time maybe anyone saw them well was the night before, then they can come in, but might be out of the time frame. So one of the biggest questions we ask in the emergency department is, when was the patient last known well, or when did you last feel normal? This is a strong medication. It's used to break down intraarterial clots. The benefits of this medication are huge. So it can have brain reperfusion if given within that time frame, and it can overall decrease the amount of permanent damage that happens to someone's brain from a stroke. However, as with all medications, there are drawbacks to giving this. It can increase the risk of bleeding or hemorrhage. This is meant to break down clots and to break apart clots. So by nature of this, you can have bleeding occur. So when we give someone this medication, we do monitor them closely. They end up in the intensive care unit. We're doing frequent neuro exams on them, checking to make sure they're doing okay. But the benefits of this can be amazing. So a thrombectomy is another way we can help treat ischemic strokes. How this is done is with a catheter, and we use this to remove an intracranial clot, and we can do this within 24 hours of blockage. So we have a longer time frame for which we can get this treatment done. There's different ways we can perform thrombectomies. One is mechanical, where there is actually a catheter that goes up through the artery into the brain, and this breaks apart the clot. Another way is aspiration. So this is actually, kind of think of it like sucking the clot out of the artery. So there's multiple ways this can work, and it can be used for a longer time frame than TPA. The benefits of this is we are removing the clot, or at least portions of it, to decrease the tissue damage. However, the drawbacks is, once again, we only have a roughly 24-hour time frame to use this, and only certain clots can be reached with the current catheters. So not every single stroke can be reached with these. And getting in and getting evaluated quick is how we can determine what of these medications versus thrombectomy will be the most beneficial to a patient. Medical management. So this is after the patient's gone through the emergency department. If they unfortunately arrived outside of the time frame, or we couldn't give TPA, or do a thrombectomy, there are still a lot of medication adjustments or medications that can be given to treat stroke. Now, this is great news because there's a lot we can do to help people. So antiplatelet medications, a lot of people know what aspirin is. It's in almost everyone's cupboard, and a baby aspirin a day is one of the most common medications we use for treating stroke. Another medication we frequently use is called Plavix or clopidogrel. This is an antiplatelet, and another one we're using more frequently now is Brilinta. All of these medications help plaque from sticking together and can help break down small clots to reduce the strokes and also over long term prevent people from having strokes. The next step up is something called long-term anticoagulation. So warfarin, Coumadin, Xarelto, and Eliquis are the most common ones we use. And once again, the theory behind this is they prevent clots from forming and reduce your overall risk of stroke over time. Statins like Lipitor, so these are cholesterol medications, can be given. This, once again, is used to prevent plaque from forming on the sides of the arteries and from forming into those clots that can break off. In certain instances, we use things called hypertonic saline or mannitol. You don't need to know everything about this, but these are medications that we use in the intensive care unit to reduce the swelling once somebody does have a stroke if necessary. These can save lives by reducing the swelling and also keeping people at a safe level of swelling. Usually these are more in the larger strokes, but it's something good to know. After a patient has had a stroke, sometimes they will have deficits that aren't just physical that you see on the exam, but also mood can change. So there are medications we can use to help manage and treat patients' mood afterward, because somebody who's in a good mood or feeling positive is more likely to work with the therapy teams and see positive strength improvements versus somebody who's not feeling the greatest about what happened to them. We understand stroke can be very stressful, but getting these medications to help their mood improve can really benefit people in the long term. Some of the other things that we do when patients come into the hospital is do an echocardiogram. So we'll look at the patient's heart to determine, is there any source of the clot that we find? Is there a hole in the heart that would allow a clot to go through it? As well as carotid Dopplers. So this is where we look at the carotid arteries on either side of the neck and see if there's any clot forming. And the last one is laboratory workup. We're going to look at your cholesterol levels. Do you have diabetes? Do you have lipids, so fats that are building up in your system that are causing these clots to form? Because all of these can be managed with medications. Surgical management. The most common ones would be a carotid endarterectomy. This is if you did have plaque or clots forming along the sides of the carotid arteries, they can actually open up the artery and remove that plaque. Our vascular team is great at performing these, and it's one of the ways that we can also in the long term reduce the risk of strokes in the future. If they cannot go on the outside and surgically open up the artery, another option is internally placing a stent across the plaque and pushing it down along the sides of the artery so that it doesn't break free and go up into the brain. Lastly, we have decompressive craniectomy. This is a very fancy term for if a patient has swelling in their brain caused by the stroke, then we can actually take off a piece of their skull to allow it to swell outward. And that's where that mannitol that I was talking about earlier comes into play, and we can reduce that swelling. And eventually, as the swelling reduces over a few days to weeks' time, we can put that bone back on. So follow-up. So this is for after the patient has been in the hospital, they've been started on medications, they've had a thorough workup for what caused the stroke. Then they end up usually following up, hopefully with the neurology office or sometimes their family medicine doctor if they feel comfortable about it. If they follow up with the neurology team, one of the biggest things that we're going to do at that follow-up visit is check on your medications. Are you still taking the aspirin, Plavix, or the antiplatelet medications that we gave you? Do you need refills on those? Also, a big one that we often ask is, do you need further evaluation by physical therapy, occupational therapy, or our speech team? Our rehab units are great here, and also these are hugely important to helping patients after stroke. Usually at those follow-up appointments, but I'll give a little tip here. For the first 6 months following a stroke, there is a good chance of fast recovery. So working with those rehab teams quickly after a stroke can cause very quick improvements. But the new baseline, so the new baseline level of functioning that we expect is actually 1 year after a stroke. So doing these follow-ups with us, making sure that we have you working with the therapy teams that you need to see, making sure you're having healthy diet, exercise, you're no longer smoking. And by doing all these things, you can significantly improve the outcome over time for all these patients who have strokes. Another one, ophthalmology and optometry. This may not seem like the most obvious thing for after stroke, but a lot of strokes will actually affect the eye and vision. People will naturally start to look and cover the areas where they're having a visual field deficit after a stroke because vision is so key to everyday life for us. But having an ophthalmologist and an optometrist that can either put prisms in to correct if you're having double vision or to help you acknowledge those blind spots and work on it is important. One thing that our clinic in particular provides, but something that's come a long way for managing stroke, is Botox. So I know this doesn't sound as obvious. This isn't for treating crow's feet, like a lot of people always ask me. This actually reduces something called spasticity. So after a stroke, people have tightening in the muscles, sometimes of their arm or their leg, and it can be really painful and debilitating. So what we can do is Botox injections into that arm and into those muscles to release the tension. And by doing that, they can get increased ability to move their limbs again and work with the therapy teams. And some people, we can even retrain how to lift weights, to do those small fine motor movements like feeding themselves. And it can also reduce the pain. Seizures. So one of the risks of anyone who has ever had a stroke is it does leave scar tissue within the brain. This leaves a spot where seizures can form. And so putting you on these medications and keeping you on them to reduce your risk or prevent seizures is important. This doesn't happen in every stroke, but for the people who do develop seizures afterward, we can manage that. And then some reasons to come back to the emergency department. Anytime that you have new stroke symptoms, new weakness, numbness, tingling, any facial droop, difficulty with speech, sudden vision loss, immediately go back to the emergency department, because the faster you get there, the sooner we can give those medications. Hemorrhagic stroke. So this is the other type of stroke I was talking about earlier. This is where you actually have a bleed in your brain instead of a clot that blocks off the artery. Hemorrhagic strokes are an emergency condition. It's usually caused by high blood pressure. Trauma is the second leading cause. And then also anyone taking blood thinning drugs also has an increased risk. So symptoms vary based on the location of the hemorrhage, but they're usually pretty similar to the previous symptoms that I reported. So people will have numbness in their face, their arm, their leg. They'll have weakness on one side of their body. Some will develop difficulty speaking, and some have difficulty walking or with balance and fall over. All of these are reasons to go to the emergency department, because there are medications that can be used to treat this, and there's also close monitoring in our intensive care unit, and sometimes surgeries that can be done to help manage this. So some of the options for a hemorrhagic stroke: coiling, clipping, and stenting. So coiling is an intravascular procedure where they actually go through the patient's artery, and they take a small coil and actually coil up into an aneurysm. So this is a small pouching. And so they'll put a coil in the aneurysm, and this can prevent a hemorrhage from that aneurysm. Another way is to place a stent holding the coil up there. Usually these methods are to prevent a hemorrhagic stroke. There is also something called clipping, where they will take, it almost looks like a clothespin, but think of it like a tiny size of your fingernail clothespin. And this is a surgical procedure, so they actually open up the skull and go through and place a clip across the tiny balloon sac called an aneurysm. This can be done if a hemorrhagic stroke occurred to stop it, and it can also be used as prevention. There are benefits and risks to any of these procedures. But the big one is these help reduce aneurysm ruptures and bleeds, and it's one of the more common causes of hemorrhagic stroke. Some of the drawbacks of these: clipping, you're going to have a brain surgery. They're opening up your skull and going into the brain. And with coiling and stenting, every once in a while, the aneurysm does return. So talking to the neurosurgeon and the doctors about these is going to be important before you decide which method to take for prevention. Unfortunately, if you've already had the hemorrhage and you show up in the emergency department, it's not going to be so much about prevention at that time as to reducing the damage. Not all hemorrhagic strokes are the same. So there are many different types of hemorrhagic strokes. There's many causes behind them, and each treatment is different. So as you can see on the images on the bottom, this is 3 different types of hemorrhage that can be treated multiple different ways. And so getting to the emergency department fast so we can get imaging, which includes a head CT usually, so that we can determine the best way to treat you is important. So one of the biggest things I'm going to keep reiterating throughout today is when you have these symptoms, please come get checked out immediately. We can do more for you the sooner you get there. This chart that I'm showing down below, it does not include instances where sometimes people will have an ischemic stroke, so they had a clot, and it will actually become hemorrhagic. So there's a lot of different hemorrhages, and like I said, get to the hospital fast so we can treat you. Medication options for hemorrhagic stroke. So should a hemorrhage occur, these patients, once they come to the ED, we get a head CT quickly, we see the hemorrhage, we do further imaging, and these patients end up in the intensive care unit. We're trying to keep the head of their bed raised. We're frequently checking in on you, asking if you have a headache, do you have any new weakness, do you have any new numbness? And we're doing that because in case anything gets worse, we want to know immediately. Hypertonic saline and mannitol that I spoke of earlier can reduce the swelling from this and the inflammation of the brain. We usually start patients on seizure medication. So any blood in the brain can irritate the brain and increases the risk of seizures. So you will be started on a seizure medication in quite a few instances. We'll be repeating imaging pretty frequently, like once daily, monitoring that hemorrhage. And we do actually start a cholesterol medication in these patients. All right, surgical options for these. I apologize if anyone's got a queasy stomach around imaging, but craniotomy is one of them, where we take off, once again, a piece of the skull to reduce the swelling. Another one is a burr hole. The difference between this and a craniotomy is we make a small hole to get the blood out. And then there's another thing, it's called an extraventricular drain, where we actually put a small drain, and to reduce the pressure on the on the brain, we let out, it's called cerebral spinal fluid. So you have sacs within your brain that hold cerebral spinal fluid, and we can actually drain some of that off so you have increased area for your brain to swell. So there are surgical options to help reduce this inflammation from the hemorrhage. Follow-up recommendations after a hemorrhagic stroke. Once again, please follow up with the neurology and the neurosurgery teams, and also see all of the therapy groups. They do a great job. So neurosurgery, likely what they are going to want at follow-up would be imaging, a repeat head CT. They want to make sure that that hemorrhage is resolving nicely and that you're getting better. And then in an instance where they did take a piece of the bone off, they would put it back on. For neurology, seizure medications is usually what we're managing, because as that blood is sitting on the brain, it increases the risk of irritation. So we'll keep you on seizure medications. And then also physical therapy, occupational therapy, making sure you have all of the referrals you need, and making sure that you're on the correct medications happens at these follow-ups. So the big reason everyone's here is, what is some of the recent advancements and current projects that are being worked on in the stroke world? So one of the biggest ones is we're working on expanding the time frame for medications like TPA to be beneficial and safe. Like I said earlier, it's only about a 4.5 to 6 hour time frame. And so there's a lot of studies going on to see how long we can give this medication, how safe it is. We are improving the catheters that we're using for our thrombectomies and how far we can reach intracranial clots. Right now, we can only get a certain distance before the catheter is too wide, but they are working on improving this. We're working on improving imaging. So our MRI scanners, These can be used to better predict the patient outcomes based on the size of stroke, the location, how much swelling is occurring, and which specific brain areas are affected. And so we can give a better idea to patients and their families when they come in on how the patient is going to do long term. We have new antiplatelet medications coming out all the time that we're beginning to use. One of the most recent ones is Brilinta, and also new long-term anticoagulant medications. And another big one that we're currently working on is better reversal agents for blood thinners that can reduce the size of hemorrhages. There are a lot of patients who come in on blood thinners, either for cardiac reasons, so heart issues, heart stents, vascular stents, also history of stroke, and those blood thinners, as I said earlier, can increase the risk of hemorrhage and also the size of it. And so by having reversal agents, we can reduce the overall size that hemorrhage gets to. So in conclusion, ischemic strokes, the clots that block off the brain's blood flow, time equals brain tissue saved. The sooner you get to the hospital, the sooner we can get you on medications, and the sooner we can get you treated, which also this reduces the long-term effects that you have from the stroke. Medications that we put you on afterward, so when we're putting you on aspirin or Plavix or Eliquis, these are usually lifelong unless some new thing happens. So if you were to come in with a new stroke or a new issue, then we would adjust as needed. If you're worried you're having a stroke, please come to the emergency department. Don't wait. For hemorrhagic strokes, there are many causes and treatment pathways. The big thing is coming to the emergency department so we can determine what caused it and get you on the correct treatment path. Some of the treatments are aimed at prevention and others are aimed at salvaging what brain tissue we can. So questions. First off, because I know a lot of people, I've done this presentation a few times, and so I'm going to go over some of the frequently asked questions I get. Hopefully that will cover things for people, but if you have any additional ones when I'm done, please let us know so I can answer them. So the first one, what is the recovering period following a stroke? I did touch on this a little bit earlier, but 1 year is roughly where we say the new baseline is. 6 months, you have a quicker recovery period. That's when we really want you focusing on yourself, working with the therapy teams, working on strengthening, getting coordination back, but you can keep getting better for up to a year, and a year is that new baseline roughly. I have seen people continue getting better longer. I've also seen people get stuck, but I like to say roughly 1 year. How long will I have to be on medication? Once again, most of the medications are lifelong unless something new happens and we would adjust the medication accordingly. If you're ever wondering or curious about, am I on the right medication for me at this time, please reach out to your family doctor or neurologist or somebody who you know can help you make that decision. What do I do if new symptoms arise or old symptoms of stroke return? Come to the emergency department or contact your primary doctor or neurologist to get checked out. We'd rather have you get checked out and be wrong than have you have a new stroke and nobody knows about it. What are the odds of having another stroke? There is no specific fraction or percentage that I can give you. Everything that we do is to reduce your risk of having a stroke, and by taking the medicine, you're going to reduce risk by taking the aspirin or Plavix or statin. It's all about risk reduction. The same goes for monitoring your blood pressure, eating a healthy diet, following up regularly with your doctors and working with the therapy teams. All of that is for risk reduction. Unfortunately, there is no medication or no way to get you down to 0%, but everything we do is to reduce the risk of having one. And then what is the difference between a TIA, a mini stroke, and a stroke? I get this one all the time in the hospital and from family members. So a mini stroke or a TIA is where you have symptoms for a short period of time that resolve on their own. When you come into the hospital, we still check you out and do all of the evaluation as though you had a stroke. And if the MRI and imaging is negative, it was likely a TIA. What we call a stroke is when the symptoms stay, so over 24 hours, or you have an MRI that does show damage to an area of the brain. And that's how we determine a true stroke. And with that, I will pass it back to Gina. And is there any questions?
Well, thank you, Jordyn. That was a great presentation, such great helpful information for our viewers. And we do actually have a few questions. So they're a little bit different than the ones that you usually get and read off. So our first one is from Ashley. If a patient has had a mini stroke, are they at higher risk for a full-blown stroke?
That is a brilliant question. And the answer is yes. So, a lot of the times when patients are having mini strokes and those stroke like symptoms, there is something brewing that is going to become a stroke in the long run if they don't get checked out. So, if you're having frequent signs of or mini strokes or signs of a stroke, it's better when you are having those to come get checked out at the emergency department or to let your primary doctor know. And a lot of times what they'll do is either refer to me or start a stroke workup even on an outpatient basis so we can reduce the risk.
Okay, great answer. So another question from Laura. Is it best to call an ambulance or can you drive yourself or a loved one to the emergency room?
This is another great question. So please call an ambulance. Not that I don't trust the driving skills of family members. Also, please do not drive yourself because at any point a stroke can worsen. The reason I actually want you to call an ambulance is there are medications that can be given en route, and they will also alert the hospital that you are coming. So we can all be ready standing there in the emergency department to get you to imaging and get you the medications you need faster. Some of our goals once you arrive in the emergency department is get you through the process of figuring out what's wrong within about 30 minutes or less. So if we know you are coming, we can work you through that process faster. Another thing is that if we see obvious stroke symptoms, they're going to take you to a hospital or center that's more focused on treating stroke. And so you'll get to locations that you need to be to faster. So always call an ambulance for these.
Okay, those are great reasons. Another question we have is from Grace. What if symptoms resolve? Do I still need to come to the hospital?
So if symptoms resolve, I still recommend you come to the hospital because then it's falling under that TIA care category. So you're having those mini strokes, you're having episodes, and we would still like to do that background workup to see if we can reduce your risk or even prevent you from having a stroke in the long run.
Great. One more question from Grace. Can you get alteplase if you are on a blood thinner?
So there are certain medications that you can get TPA on and certain ones that you can't. And it's better to come to the hospital and get checked out and have the experts make the decision rather than just saying, I'm already on a blood thinner, so there's nothing that can be done.
Okay. Well, thanks again, Jordyn. This sharing your time and knowledge with us is really going to be helpful for a lot of people. And if you're watching this after our live presentation, please feel free to still leave a question. We'll get that forwarded to the right person and they'll be able to respond to you. So check out our upcoming health screenings and education programs on our website. You can go to mclaren.org/Bay Region and click on events. So thanks again for joining us and have a great day.